Good afternoon, everybody. It's afternoon already. It's 12:15, so we may have some more people trickling in, but I figure we can get started. Welcome to the workshop on your eyes and chronic graft-versus-host disease. My name is Jackie Foster, and I'm a patient education specialist at Be The Match. I'll be your moderator this afternoon. And it's my pleasure to introduce Dr. Ann Steiner. Dr. Steiner is director of the Ocular Surface Center at North Shore LIJ Health Systems, where she treats many patients with chronic graft-versus-host disease and other ocular surface disorders. Dr. Steiner provides a variety of therapies to help patients with ocular GVHD, including the PROSE system, which has been available at select hospitals throughout the United States. Joining Dr. Steiner is Melissa Baker. Ms. Baker is a nurse practitioner in the Adult Blood and Marrow Stem Cell Transplant Program at the John Theurer Cancer Center at Hackensack University Medical Center. She has authored several publications on complications of allogeneic and autologous transplant and has a strong interest in chronic graft-versus-host disease. Let's welcome Dr. Steiner and Ms. Baker.
Good afternoon. Thank you for having me here. It's my pleasure to discuss something that we treat on a daily basis by the North Shore LIJ Health System, which is ocular graft-versus-host disease. I'm not going to focus so much on general graft-versus-host disease. We're really going to focus today on the eyes. But just one slide as an overview. We know that graft-versus-host disease, the incidence is between 10 to 80% after a transplant, and there are various factors that can increase or decrease your risk. More specifically about the eyes are affected in up to 60% of patients, and it can often be the first sign of GVHD. So it's not uncommon that we get called to the oncology floor at our health system with a patient who's complaining of decreased vision, pain, and I think that the oncologists are trying to rule out any infectious etiology. But when we actually see the patient, we find that they have ocular graft-versus-host disease, even without a previous diagnosis of GVHD. Generally, it affects both eyes, but usually one eye is worse than the other. It can be independent of any systemic manifestations. It could be in the absence of any systemic manifestations. And like I said, it can be the heralding sign of any flare of graft-versus-host disease. And something that we look out for in our patients is it can appear as systemic medications are tapered. So ocular graft-versus-host disease is a chronic disease. It can be debilitating if not treated appropriately, but it's very rarely sight-threatening, and we'll talk about the things that can happen. Despite attentive care, patients generally feel that they have a surface-related blurred vision. So, just like when you have a windshield wiper that needs to be changed, it just seems like everything is a little bit hazier than it should be. Disabling foreign body sensation, and what patients tend to tell us is that they feel like there are rocks or pebbles in their eye. Burning, to the point where you feel like something is really stinging you and you can't keep your eyes open, and disabling photophobia. And I know that when I walk into a room and the lights are off, we have something we need to address, and it's not uncommon. So the ocular manifestations, and the reason why the top two are bolded is really because that's what we see on a daily basis, and that's what we're going to spend the most time talking about today. So Keratoconjunctivits Sicca, and we'll talk more about what the definition of that word is, but just simplistically, it's dry eyes. Filamentary keratitis is another thing that we see in severe dry eyes, and we see it often in ocular graft-versus-host disease. Conjunctival and corneal epithelial erosions, and what that means is just there are scratches on the surface of the eye. So the surface of the eye dries out to the point where it can't keep it lubricated, and then you get scratches. And if anybody's ever had a corneal abrasion, a scratch on their cornea, it's extremely painful. If those scratches don't heal because of chronic dry eyes, you can get corneal ulcerations, where the cornea thins out to the point of perforation. You can actually get a hole in your cornea. That's rare. The top two things are really what we see every day, but it can happen. It's something that we keep in the back of our minds when we treat patients with this. Pseudomembranous conjunctivitis is more in acute GVHD than in chronic GVHD, but it's a severe conjunctivitis that we have to treat aggressively. And endophthalmitis, it's all the way at the bottom because it's the most rare, but it's an infection in the eye, not on the surface of the eye, but inside of the eye, and that's extremely rare. So we're going to really focus on the top two things, which is what we see every day. Just to give a little background about Keratoconjunctivits Sicca, again, dry eyes. When we think about dry eyes or lubricating the eye, I think that we think it's simple. You know, you have an eye and you have tears, and the tears lubricate your eye. It's actually much more complex than that. So just to go into some details of the tear film actually has 3 components to it, and they all have to be made in the right proportion in order for your tears to function the way they have to function. The back part of the tear film is a mucus layer, and the mucus layer is what sits against your cornea and allows the tears to spread evenly over the cornea, allowing the tears to actually do their job, to coat the whole cornea. And you can see here, this is a cornea, and the tears have to sit on that. The aqueous layer is, I think, what we all think of tears, which is the water component. That component is made by the lacrimal gland, but that's only one of the 3 components of the tears. And the most anterior, the most superficial layer, the one that's exposed to the environment, is the lipid layer. The lipid layer is what prevents your tears from evaporating the minute they're made. You want to keep your tears on your eye so that they lubricate your eye. And the lipid layer is what keeps the tears on your eye for a longer amount of time. Now, all of these have to be made appropriately and in the right proportion for your tears to function and actually lubricate the cornea. Just trying to get that back. The mucus layer and the lipid layer comes from these glands that are on the eyelid. So after these glands and the lacrimal gland all make the tears in the right proportion, after they've done their job, then they can drain out of the lacrimal system over here, which is on the inner corner of your eye. So what we see in Keratoconjunctivits Sicca is that kerato means cornea. Conjunctiva is that white skin-like membrane that covers the other parts of the surface of the eye. Itis, keratoconjunctivitis. Itis is just inflammation, and sicca is dryness. So there's a lot of inflammation on the cornea and on the conjunctiva because the eye is so dry. And the reason why you have this dryness is because there's infiltration of the T cells into the lacrimal gland, which causes destruction of the lacrimal gland, and then the body doesn't make the tears appropriately anymore. We have reduced tears, altered tears, and dry eyes. And this is just a big quote as to the definition of dry eyes, but if you can see here, it causes discomfort, visual disturbance, and a potential damage to the ocular surface. So again, what do patients tell us when they come in? Foreign body sensation, there's something in my eye, I have severe burning, a dry sensation, light sensitivity, blurred vision, and in general the symptoms are worse towards the end of the day. Makes sense because your eyes are open throughout the day, the tears evaporate, the longer you have your eyes open, the more dry it's going to feel. And on examination, when we actually examine our patients, what do we see? Bulbar conjunctival hyperemia. The eyes are red. There's less tears than we would expect in a normal eye. The surface of the cornea is irregular because it's not coated well. And we have what we call filamentary keratitis. I'm going to show you some pictures of this. Both of these pictures are on our examinations when we put fluorescein onto the eye. So fluorescein is a stain that sticks to the eye in areas where there is a lack of surface cells. So on this eye, this is severe dry eyes. There are multiple hundreds of scratches. All those green dots on the surface, those are scratches on the cornea. And that's extremely uncomfortable. It's very painful. And that's because the tears are not coating the surface well. It's allowing the cornea to dry out, and the cornea has hundreds of scratches all over it. This is filamentary keratitis. This is something else that we see in very dry eye patients, where the surface cells, the epithelial cells, actually, because they're so dry, slough off of the cornea and then stick to each other. And they cause this stranding. We call them filaments. And it's actually like a rock on your eye. So when patients say, I feel like I have a rock on my eye, sometimes they actually do. And you can imagine if you blink over these little strands, it feels like there's a rock. So that's extremely painful. So how do we treat this? We've gone through all the symptoms. They sound pretty bad. The good thing is that we usually can treat this pretty successfully. We're going to go through all these treatments. Start off simple to a little more complex, but in general they work pretty well. So, lubricants. So I always start with tear supplementation. Your body's not making enough tears, let's supplement the tears. I prefer preservative-free artificial tears. They come in little plastic vials in a cardboard box. They have no preservatives in them. They're not going to hurt you. There's nothing bad about it. And I tell my patients to use them every hour. Just put them in every hour. Nothing bad is going to come of it. And then at bedtime, I like to use gels or ointments. I tend to recommend Gentile gel. I've had great success from it, but there are other gels on the market. And the point of the gel is that it stays on the surface of the eye while you're sleeping, so that in the morning you're more lubricated when you're going to start your whole day. Cyclosporin, or Restasis, is something else on the market. The goal of Restasis is to decrease inflammation in the eye and to allow your body to make more tears. Just going to be very honest with you, I personally don't have great experience with using Restasis in my GVHD patients. There are patients who think it does work for them. I encourage them to use it if it works. But for the most part, I don't feel that it works very well for my patients. It does burn sometimes when you put it in, so I don't use this on a very regular basis. But the dosing is twice a day in general. Okay, so corticosteroids. This is an off-label use for steroids, but basically dry eyes is not just that you're not making enough tears, but then your eyes get inflamed. Once you get inflamed, the eyes don't make enough tears, and it's a cycle of inflammation. And so steroids stop that cycle. It kind of breaks the cycle and allows your eye to be less inflamed, more comfortable, and possibly make more tears. I use this very, very often. We use a compounded preparation, which is preservative-free and an extremely low dose, just to get a little bit of steroid onto the surface of the eye. It decreases pain a lot. It allows patients to function better, and I do use this quite often. Sometimes you could use just a 2-week pulse, allow yourself to break that cycle of inflammation, and then just continue with tear supplementation. Or sometimes you need a longer dose, but in the preparation that we use, it's very dilute, so I'm comfortable using that. Autologous serum drops. These are drops actually made from the patient's serum. Blood is drawn, spun down, the serum is extracted. It's made into an eye drop preparation, and patients use it. The benefit of it is that it has very similar growth factors to normal tears. So patients do experience relief from it. There's good literature. The problem with serum tears is that it's actually difficult to get made. There used to be more available vendors that would prepare it. Now it's kind of difficult, and it is an out-of-pocket expense. But if somebody can manage to get it, sometimes it does work. It's not foolproof, but sometimes it does work. Punctal plugs. So there are different forms of punctal plugs. And if you think back to that original slide where you're making tears and you're draining tears, if your body is not making enough tears, you would rather keep your tears on the eye for longer and not allow them to drain out. So we occlude that drainage, that lacrimal punctum. And you can see here a plug. There are various forms of plugs. There's silicone plug, the collagen plugs, but it basically stops the tears from draining out of the eye and allows you to keep your tears on your eye for longer. It says here it's reserved for patients with severe disease who have failed medical management. I'll be honest with you, I use plugs all the time in my GVHD patients. I think it works. I think it helps. We want to keep whatever tears you are making on your eye and not allow them to drain out. And then there's something called punctal cautery, where we actually permanently close up the tear drainage system. And we do this in severe cases where we feel that we should never allow tears to drain out again. I don't use it that often, but it is an option if we need it. Moisture chamber goggles. I don't know if anybody has tried these. You can get them online, actually, and it just allows the eye to be more lubricated. There are various forms of them, and there are various supplementations that you can put on your glasses even to keep decreased airflow through the glasses. It's available. A lot of patients don't like to use them. And then this is another thing that we're using now, and this is really the crux of what I wanted to talk about, is therapeutic lenses for the treatment of chronic GVHD. So the goal of these lenses is to promote healing of the cornea, to provide mechanical protection of the cornea so that you have something on the eye that's protecting your cornea and maintaining hydration. It's constantly lubricating the cornea. It relieves pain almost immediately when we try it. And the positive side effect that we have is it actually improves vision. There are various forms of therapeutic lenses. You can use a soft contact lens as a therapeutic lens. Unfortunately, in GVHD patients, the eye tends to be too dry to actually use a soft lens, and the lens dries out and just falls out pretty quickly. So we don't use that very often. There are various forms of scleral lenses that are not quite as customized. It's not always possible to fit every eye with those kind of scleral lenses, but we can try. And again, with all these lenses, you do need a specialty fitter. And then the last lens that I want to talk about, which is really more a prosthesis, is called PROSE. And it's a very highly customized prosthetic device that we use in our treatment of chronic GVHD. So this is a picture of an eye that has the PROSE device on it. You can see the eye is not red at all, and you can actually see the edge of the device over here. This line here is the patient's cornea. That's just a reflection of the cornea. This line here is a reflection of the device that's sitting on the eye. And this space between those two lines is sterile fluid. So that eye is constantly being bathed in sterile fluid, allowing the eye to feel comfortable and lubricated at all times. In order to offer this treatment, you need a specialist, a cornea specialist who's an ophthalmologist. You need an optometrist who's highly trained in this. You need other trainers in order to help the patient. And then you need engineers and technicians. And we partner with Boston Foundation for Sight, who actually makes the devices. PROSE stands for Prosthetic Replacement of the Ocular Surface Ecosystem. So it's actually a prosthesis. It replaces the function of a normal ocular surface. It restores vision, it supports healing, it reduces symptoms, and it improves patients' quality of life. So why do I say that it's a prosthesis? Well, the ocular surface is made up of the eyelids, which goes into the conjunctiva, which is the skin-like structure on the surface of the eye, the cornea, and then this is the tear film. And the PROSE device actually functions in all of those manners as a prosthesis for that system. So it protects the cornea from any diseases that could be on the lid or the lack of closure of the eyelid. It functions as a tear reservoir, so it provides the tears that are not there. It masks any irregularities on the surface, so it can actually change the shape of the cornea. And it covers the conjunctiva as well, and it protects it. So it replaces and supports the functions of a normal ocular surface. And here you can see as well. Over here would be the lens, the device. Over here would be the cornea, and in between, that green would be stained fluid. So that's actually sterile fluid that's lubricating the cornea. And that sterile fluid reservoir functions as a liquid corneal bandage contact lens, basically. It masks any surface irregularities, and it provides this constant lubrication. So the Boston Foundation for Sight conducted in 2005, they conducted a retrospective, just a phone survey where they asked their chronic graft-versus-host disease patients how they were doing. And they found that they had marked improvement in pain and light sensitivity, as well as improvement in their function, their quality of life, better driving and reading skills. And this is an update. In 2010, they looked at a 5-year follow-up of their patients and found that the PROSE treatment had a long-term impact, so that greater than 70% of the patients that they fitted with the PROSE system were using the device 5 years later, and it increased their visual function and quality of life. So the main problem, honestly, that we are having is not the quality of life for our patients. Our patients are very comfortable, are very happy, and do notice better function. However, we do have insurance issues. In general, insurance companies feel that contact lenses are cosmetic devices and they don't need to cover them. We are working very closely with the Boston Foundation for Sight, with Medicare and other payers in order for them to understand that we are not treating a cosmetic contact lens. We are using this device as a medical service for patients who need it in order to function. We are getting through to some insurance companies, and we are being very persistent and stubborn, but that is the problem that we are having. We know that it's something that we can offer our patients to improve their life, but we have to fight. So just to review, how do we look at our treatment of ocular graft-versus-host disease? We start with lubrication. We use that as much as we possibly can. I use steroid drops, rarely Restasis, sometimes serum tears. I basically always do punctal occlusion. Glasses and goggles is an option. Therapeutic contact lenses, and PROSE. And we're lucky to have this treatment because I really do feel that it works. All these things have a minimal likelihood of side effects. So we do stick to local treatment. We can work with the oncologist for systemic treatment, and generally we do that when there's vision-threatening disease. Okay, and so these are the different things that the oncologists can offer patients if there is vision-threatening disease. Again, that's rare. So just to conclude, ocular graft-versus-host disease treatment is available that does improve quality of life for patients. You should see an eye care specialist who's informed about the options and experienced in treating ocular graft-versus-host disease. And you can see here, this is a patient who, before treatment, all these hundreds of scratches, and after treatment, the ocular surface looks relatively healthy. Thank you.
Great presentation. Could you discuss the effects of low white blood cell counts and low platelets for extended periods, and that would be prior to transplant and then after in the eye, and what are the lasting effects of that of that?
So aside from graft-versus-host disease, you're saying? Yeah, anytime there is a low white blood cell count, there is a risk for having infections in the eye. That's one of the things that we pointed out with an endophthalmitis. There are patients who do have endophthalmitis in the setting of immunosuppression. Low platelets, in general, we do not see a tremendous side effect from that, but there can be spontaneous bleeding in the eye from having low platelets. And actually, I was just discussing, there were a few patients who were immunosuppressed who did have unusual infections in their eye that were seen in Hackensack.
Okay, and then post-transplant, the use of extended long-term steroids, specifically prednisone, most of us are on that.
Yeah, so we do see cataracts formation with chronic steroid use, elevated pressures in the eye. The good news is that cataracts are reversible. We can do cataract surgery to remove the cataract, replace with a clear lens, and you don't have to worry about that coming back again. And in general, the elevated intraocular pressures that we do see from chronic steroid use, we can treat with drops if needed. So those are all treatments that we can offer.
Any other questions? Looks like right here in blue.
Again, great presentation. I see an ophthalmologist who's fantastic, and I just had not just, but a couple of years ago, I had my cataracts surgery done, which was great with power lenses and all that. And now, of course, I have chronic GVHD in the eyes, and about a month or two ago, my doctor started me on Restasis. And I'm not so thrilled with it already. She said I have to do it for 6 months to start seeing an improvement. Every time I put it in, it burns, and I'm not liking it. And you recommended another one.
Yeah, so like I said, there's a lot of publications on Restasis, and there are great commercials. I just haven't seen my patients do well with it.
Yeah,
and we were just saying, that sometimes I feel that there's more tears produced because you cry when you put it in. But
not really.
I mean, it's just not my great treatment. So what I do, first of all, you should be using lubrication.
I do.
Preservative-free artificial tears.
I think Retain. I use Retain. Is it?
Just check to make sure it's
Sustain.
Oh, Sustain is, as long as it's preservative-free.
Right.
I really think it's important because in GVHD you tend to be more inflamed. If
Right.
you put things in the eye that have preservatives, it can increase your inflammation. So really everything has to be preservative-free. And the other thing that I use very often is, you have to have it compounded, but it's a preservative-free, extremely dilute steroid. It's preservative-free dexamethasone. We actually published a paper on this in a 0.01% solution. Very low dose, but it provides enough steroids in a preservative-free fashion that it really does break the cycle of inflammation, and patients see an effect within a few weeks that they just feel better.
And I can get that through my ophthalmologist?
You can mention it to your ophthalmologist. He has to have a way of getting a compounded medication made, and because it is a steroid, you do have to be followed. So in general, I see patients monthly if they're on a steroid drop, just to make sure that the pressure is okay in the eye, that they're not having any side effects. But again, we published a paper on this, and the effects were really minimal. The side effects were it was a good profile, and I use it often.
Great. Thank you.
Just also to speak to the cyclosporin, I happen to agree absolutely that our results with our patients as far as treating graft-versus-host disease have not been plentiful as far as the use of Restasis, although there is a role for some patients for this medication. As well, the cyclosporin has been used in other roles for our transplant population. Perhaps there was a recent study that just ended using cyclosporin implants as well as cyclosporin eye drops to prevent ocular graft-versus-host disease, which may be very promising. So I think it does hold some strength, but perhaps not greatest strength in our patient population as far as chronic graft-versus-host disease. But I agree. I think the pulse steroids or the low-dose ocular steroids are great, as well as the lubricants.
And punctal occlusion, I think, is a mainstay of treatment. For the most part, if a patient comes into my office and they have chronic graft-versus-host disease, it's like, hi, nice to meet you. Here are your punctal plugs. And I just think that it's something that is easy. It doesn't require anything from the patient. You don't have to be worried about taking them in, putting them, you don't have to do anything. They're there. They stay for the most part. And they provide just more lubrication without any effort.
We've got cataract lenses.
No problem. Yeah, it doesn't. There's no contraindication. So you can mention these things.
We've got lots of questions and lots of time, so let's start hearing here.
I just have a comment to make. I have PROSE lenses, and I had graft-versus-host disease that I got about 6 months ago of the eyes. Got progressively worse and worse. And my doctor actually sent me to the National Institute of Health in Bethesda, and they said, she went down the list with me and she said, you're going to wind up with PROSE lenses. Well, I did wind up with them. They're very expensive. They require a lot of learning, but they are life-altering. They took away every symptom. The Restasis never worked for me. Mm-hmm. And they said, you'll be able, because I was taking the steroid drugs, they were raising my pressure. So I'm still going. I go to Gotham from Cornell, and they're wonderful. That's all I could say. But you need patience. You need Medicare will pay for part. Horizon, I'm still fighting the battle, and I intend to keep going with them. They will not, they're calling it a, they said they don't pay for prosthetic devices. So I wrote them a letter, and I wrote the letter to Medicare also, and I said, if a man gets his leg cut off, and you give him an artificial leg, aren't you going to teach him how to use that leg? And that's what I'm asking them to do, to pay for the office visits, because they won't pay for 6 months' worth of office visits, which is considerable. So they will pay for the device. So the bottom line is, I paid, and I would have paid anyway, because when she put that thing in my eye, it was like magic.
Yeah, I think that anybody who's fortunate enough to be able to offer this treatment to patients, we're lucky to be able to see that all the time. We have patients come in, you put it on,
really
and
a magnificent thing.
Yeah, but I do agree that the main obstacle is the insurance obstacle, and it's frustrating. It's frustrating from everybody because we know we have this treatment that we can offer people. We know it works, but we can't get through to insurance companies.
I filed my first appeal, so we'll see. With
Good
Medicare.
luck. Stay strong.
We have the first row here, and then on the third row there's some more. So everybody.
Hi, my name's Susan. I had my bypass back in 2010. Anyway, I am on a regimen of Restasis 4 times a day, the Refresh 4 times a day, and the Refresh gel 4 times a day while I'm waiting to find out if I qualify to get the PROSE lens. But meanwhile, when my eyes burn profusely, my nose drips profusely. And other people that I have talked to this weekend that go through the same thing said that they don't have that. But I don't know, is there a possibility that it's connected or is it a separate
It's absolutely connected.
It is?
So let me just show this image one more time. Okay. So when your eyes burn, your body sends a response to this lacrimal system to produce more tears. There's something wrong with your ocular surface. You need something to help. Let's produce a lot of tears. In general, those tears that you make in that kind of response, like a response to some pain or something, they don't work very well. They're not very functional tears because they're not made in the proper proportion. So you're making a lot of tears, and then they drain out of your lacrimal system. This nasolacrimal sac, it's called a nasolacrimal sac because it drains into your nose. So you're producing a lot of tears. They drain straight through here, out, and through your nose. And so your nose starts to run. Clearly, you don't have any punctal plugs in because if you did, you would be blocking that response and keeping those tears on your eye for longer as opposed to allowing them to drain out. So I'm a big proponent of punctal plugs. Big. You can always take them out if you don't like them.
I do have that.
Well, I would have that checked. Check that, because that should be blocked then. It shouldn't be able to drain.
Okay, so then it's a separate issue.
No, I have a feeling that you should have your plugs checked just to make sure that they're really occluding.
The last time I was there, they were. I was there in June.
Okay, so maybe it's draining through your upper punctum, through here. So you may not have your upper one plugged.
They're all four of my orifices have been plugged.
That's going to be my favorite quote of the day. I love it. Well, then I don't know why you're draining through your nose because it should be blocked. So like I said, I would just bring that up to the person who's putting your plugs in and just make sure. That's the only thing I would say, is just make sure, because your eyes and your nose are absolutely connected. That is a normal system, but if it's plugged, it shouldn't be allowed to drain through your nose.
Okay.
So just check it.
Okay.
Hi, I wear the, I'm not at the PROSE lens yet, but I'm wearing the Band-Aid, the soft lenses, and I find that you called them rocks, I call it glass, like things like they still will build up behind the lens, and that's really painful.
Yeah.
You know, because now the lens is on top of that, and I'm wondering if I were to go to the PROSE lens, would that happen with that also?
So I believe there's a big difference between the PROSE, I'm just going to get to that picture, the PROSE device and your soft lens. Your soft lens sits on your cornea. So what it's really doing is just masking your irregular cornea from your lid and from the environment. But it's not providing you with extra lubrication. So you're still going to get dry because you haven't changed that part of it. With the PROSE, you have the device sits above the cornea. So it doesn't touch your cornea at all. And what sits on your cornea is fluid. What's sitting on your cornea with the soft lens, although it probably does help you somewhat, is the cornea. So you have your lens and cornea, but no fluid.
Right.
So you haven't added that extra step of the tears, whereas with the PROSE, you have that fluid reservoir that's lubricating your surface, and so you shouldn't get dry on your cornea anymore because you have this bathing system.
Right.
Just to add, of our patient population that have used PROSE that have had similar symptoms as you're describing, I can't recall any of them that still have that sandiness, grittiness once they started to use PROSE.
What can happen is that the surface of the PROSE, I don't know if you've experienced this, the surface of the PROSE can still dry out. So because you're not producing tears, your cornea is perfectly healthy because you have a bathing system on your cornea, but the surface of the PROSE device can still dry out, and so you still need to put in sometimes tears in order to lubricate the surface of the device, not so much your cornea. So you won't be in pain, you won't be uncomfortable, but you'll notice that it dried out on the surface, and so then you need to put in a drop or two.
Is this something you change every day?
Yes, you take it in, and you take it out, put it in every single day. Yeah, you don't sleep in it in general.
Thank you.
I just want to add one thing. When you take the device out at night and put it in its head, you have what's known as a residual effect on your
eye. Because your eye has been bathed in liquid all day, you don't have those dry eye symptoms badly at night. So I take it out about 7 or 8 o'clock at night, and for the rest of the night, my eyes are pretty good without the PROSE lens. Okay, if I need a drop once in a while, I was putting drops in like I'm telling you, every 5 minutes. Literally.
And by 7 or 8 at night, that's it.
You had it. You had it. My eyes were like slits. I couldn't stand the TV light. So now, when I take it out, because you can't shower with it, you can't get it wet while it's in your eye. And you can only have a half-hour nap. So you got to keep going. And the thing is that once you take it out at night, and I take it out about 7 or 8 o'clock, watch TV in reasonable comfort, not use flopper too, and then I go to bed at 11 o'clock. Next morning, I can't wait to come in because my eyes are burning.
Do you have another question at this point? Both of them now?
Hi, I was a patient of Dr. Hessen at Hopkins, and they are pushing the PROSE lens, and I did get it approved through insurance through their efforts. But they're absolutely right. It is very expensive. I've heard of quotes as high as $14,000 for them. So it's worth pursuing if with insurance.
Well, my first comment is that I used to have extremely dry eye, and Restasis never worked for me. One thing I did was taking omega-3, though. It helped out a lot with the dryness. So if you haven't tried that, please do it. And you don't have to have it as a supplement. You could eat salmon. There's other food with an abundance of omega-3.
That's a great point. Actually, the omega-3 fatty acids, the fish oils, they work on that, the other components of the tear film, not the aqueous component so much, but that mucin and lipid component. And so if you strengthen those components again, you need everything in the right proportion. It does help. So that's a great point.
But my problem is at night, I'm not too fond of putting gel in my eye. I don't really like anything going in my eye, but I have to do the drops anyway. But the gel, I'm not too fond of that. Is there anything else I could do for nighttime?
We have this conversation in our office all the time. I am a big lover of gel. I love it. I think it works. I think it gives you a reserve for the morning when you wake up. There are lots of patients who just don't like it. They do make like liquid gel kind of drops that are thicker, and so they also have that dissolving property, but they don't work as well as the gels. I don't know if you guys have any.
Yeah, I mean, some patients just don't like the gel, and for those patients, we would say the liquid gels, but otherwise, the Gentile gel and the other gels.
It's not the same.
Okay.
I want to go back to the Pro lenses, if I could, because it sounds like it could be maybe a lifesaver here for my wife. So, I want to go to the insurance piece of it so I can understand, because that's part of my game in this experience. And I wanted to ask if anybody can share where they've had successes with dealing with the insurance industry with regards to Pro lenses.
I just want to point out, just for 1 second, in the back is Melissa from Boston Foundation for Sight, which is really the hub of all of the PROSE treatment. Boston Foundation for Sight produces all the lenses and has satellite facilities that are affiliated. So we are one of them. As you mentioned, Cornell is one of them. But everything comes from them. And they are taking an initiative to work with insurance companies and try to educate them, and they've hired consulting companies as well, because we know this is our major obstacle. If you want to speak to that as well. And also, Dr. Busiak is our PROSE trained optometrist who works in our facility and actually does the fitting of all the lenses at North Shore.
How about the University of Pennsylvania? Is there any contact down that way?
No, I'm aware of. We just announced that we're opening a new clinic in Rochester, which is not near Philadelphia. Our first satellite clinic opened in 2008, excuse me. And so since then we've opened an average of 1 or 2 a year. So we hope to eventually be, within 500 miles of everybody in the country, but we're not there yet. As far as insurance goes, for a very long time, we were the contact lens people. And that's been, a continuing issue with insurance because, as Dr. Steiner said, insurance companies don't pay for contact lenses. So over the last couple of years, we've been able to, start to educate the insurance companies. Thank you. Start to educate the insurance companies on what it is that we do and why it's a medical intervention. And it is different at every clinic, simply because every state has their own insurance, and each of the millions of insurance companies have all their own policies. So it might be beneficial if you've had a consultation and you're a candidate for treatment and your insurance doesn't go through. If you can try another clinic, it might not be a bad idea because, sometimes different clinics will accept insurance that another clinic would not. So it's an ongoing process. We are working actively with, all the major insurance companies and some of the minor ones as well to try to expand, coverage. And we do get new policies, every year, new companies that, will pay for the treatment.
So we choose what clinic?
Mm-hmm.
And there's multiple clinics in the Northeast?
Yep, there are clinics in the Northeast. There's the one in Boston. There's Weill Cornell. There's North Shore LIJ. We also have one in Baltimore at the Wilmer Eye Institute. And that's all in the Northeast right now. But I do have some materials that I'll hand out as you guys leave, and there's a whole list of the providers on the back.
Hi. I did have a transplant, and I do have extremely, extremely dry eyes. Nobody ever said GVHD, but maybe that's what it is. But in addition to that, they found some, I had NHL, non-Hodgkin lymphoma. They have found some conjunctival lesions, which they think are precancerous. They were removed from one eye, but they weren't cancerous, but could be developed into cancer, and so that's being monitored. With that extra component, do these things all apply?
Yeah, I don't think I would change the treatment. I would just continue to monitor it. There are actually drops that are used sometimes to treat those precancerous lesions so that surgery can be avoided. And they do respond pretty well to drops. But I don't think that issue would change any of my treatment options here.
All right, so if money weren't a factor, which could be very largely, PROSE would be possible?
I would say PROSE would be I would have to take a look and make sure.
Yeah, but it's not ruled out
But I wouldn't say that was a contraindication.
Okay, they can't use Restasis because that would compromise my immune system, which they're saying is doing a halfway decent job on these lesions that are there in the first place. But I don't particularly want Restasis anyway. Okay, thank you.
Yeah, I think we would have to see exactly what they are, but one option would be to treat those with drops to try to see if they go away.
Hi. I just have some general PROSE questions. I don't know if it was something that's generally done bilaterally or you do it in one eye at times, if an astigmatism will have an effect on it, if it's used for corrective vision as well, and if you're looking at this as something of a permanent solution or it's just a temporary solution.
Okay. Well, excellent questions. So the first question was... Okay, yeah, that was it. Right. Generally in GVHD, it's a bilateral condition, so we fit with both eyes. There are other conditions for which we use PROSE that are one-eye conditions, but with GVHD, it's a systemic thing, and it affects both eyes, so generally we fit both eyes. It can correct for astigmatism, and it can have a prescription in it so that you don't need glasses anymore. Usually for distance, and then you would need reading glasses, but it would usually take away your need for glasses for distance, at least, to counteract all your astigmatism. And we do think of it as being a long-term solution, but there are patients who wear it for a number of years and get better and feel better and then stop using it. So there are other scleral lenses available. They are not customizable so much, so you get what you get. And if it works for you, that's great. And if it doesn't work for you, then we can't manipulate it. So there are some patients that we do fit with a general scleral lens, but we can't manipulate it as much as the PROSE. And so sometimes it works, sometimes it doesn't, and we move on. Whereas with the PROSE, every aspect of it is customizable. So we really can fit almost every eye with patients.
With the scleral lens, it starts with the lens. The doctor gets a prefab lens that they use with you. With the PROSE devices, it starts as a plastic plug. Every single device starts as a chunk of plastic that's about, the size of a wide quarter, about an inch-high quarter. And then they use custom CAD/CAM technology to design it to the exact specifications of your eye, which isn't something they can do with other scleral lenses.
Other comments? Questions? Yeah, right here. So for patients with
So for a GVHD patient who is freaked out about the idea of putting anything on their eyes, how long does GVHD how long might it take for it to resolve? If it does, will she get better on her own?
I think that's a hard question to answer. People can get better on their own, and people can get better with other treatments. There are other options. All those things I listed before the PROSE, I do. I mean, it's not like I see a patient, I say, hi, you need a PROSE lens tomorrow. I do try almost everything else first, and there are lots of patients who come into my office thinking that they need a PROSE, and yet they do well with other things. So not everybody who has chronic GVHD needs a PROSE, but it works, and it's something that we have that when we do exhaust all the other options, if that is what happens, we know we have this thing that works. We do see patients, like I said before, who just get better over a few years and they don't need it anymore. But we do see patients who are wearing it, like the study showed, more than 5 years later, and it's changed their quality of life.
I think the other thing is that sometimes it's important. Well, it's always important to address the dry eye syndrome, especially because if it goes unaddressed and you have chronic dry eyes that is untreated, you can have further complications that could be more difficult to treat. So being proactive, not so much reactive, can be beneficial, Julie.
I just have a general question. Is there anything specifically I could look in his eyes to see if my husband's got a significant graft-versus-host disease? And I'm finding out every time we go along, there's more and more parts of the body that are affected. Is there anything I could do to, if there's no dryness, really horrible dryness, does that mean he definitely doesn't have it? Or is there something else I could look at? If there's redness or in the mouth, I know you got to look and see that there's different, it's like a comb that looks like in there. Is there nothing?
Not really.
So it's only if I see,
if he's
I never even asked him about
we
that.
would be able to, on exam, under the microscope, see if there are other signs of dryness, if there's scarring on the conjunctiva, things like that. But for you to look at it would be hard for you. But I think for the most part he would be telling you that he was uncomfortable.
Right, because he just went right to he's got to have he has to have cataract surgery because he's been on so much prednisone.
Right.
And I think that's what he thought a lot of, if he did have, he really never complained about the dry eyes.
Yeah,
Yeah, I think some of it is also for the oncologist to ask the appropriate questions. Is it a disturbance in your visual acuity versus is it that sandiness, grittiness, dryness, excessive tearing, sensitivity to light? And by asking the appropriate questions, you can usually direct the patient on the right way to address it.
Yeah, but cataracts, on the other hand, is not a sign of GVHD. It's just a secondary manifestation of all the medications he's on. Yeah.
I have a quick question. I have the lubricants. Mine is called Retain. I don't know. It's non-preservative. It's called Retain, not Sustain. And
I tell all my patients I have no preference when it comes to preservative-free tears, as long as they're actually preservative-free. So there are ones that say preservative-free in the eye, and they're in a bottle. I don't like those because they do have preservatives in them. They just say that there's a chemical conversion when it hits the eye that the preservatives go away. I don't necessarily trust that, and I've seen patients who have had effects from that. So as long as it's in little vials and
Yes.
it's actually preservative-free, I have no preference.
Okay, and my other question is that little vial. There's
know.
plenty. I feel bad. I have to throw it out.
I know.
I tend to save it at least for a day.
Yeah.
For that day. Is that wrong?
Yeah.
Am I supposed to throw it out?
Yeah.
And they're
It's
expensive.
like I'm backed into a corner, It's technically, once you open it, you're supposed to throw it out. Can I say you don't have to? No, I can't say that.
Especially if
Do
you use it every
patients do
5
it all
minutes.
the time? They do. People recap it and put it in a little, shot glass.
Yeah.
Yeah, but I can't promote that, especially recorded. And so, we'll leave it at that. It's probably not really related. Could I imagine a situation where it could be if you're rubbing your eye, if you're irritated, if there's a lot of friction because you don't have a lot of lubrication on the surface? Yes, you may have a low platelet count additionally or clotting issues, but I wouldn't worry about it, is my bottom line with those kind of things. It doesn't affect the vision. It's not dangerous. It's nothing that you have to worry about. And if you use the PROSE, it could be that you would have that as well. It won't resolve that issue because you'll be manipulating the conjunctiva, so you can get those blood things, the little tiny bleeding vessels, but it's nothing that I would worry about. It's just cosmetically scary looking sometimes.
Two more questions.